Welcome to the Emergency Management and Preparedness Inclusion of Persons with Disabilities webinar series. I'm Louis Krause from the Pacific ADA Center, your moderator for this series. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon in the meeting control toolbar. To toggle that meeting control toolbar permanently on, press the Alt key once and then press it a second time. As always in our sessions, only the speakers will have audio. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-669-900-9128 or 1-646-558-8656 and use the webinar ID 155545130. I do want to remind everybody the webinar is being recorded and it will be able to be accessed on the adapresentations.org website in the archives section of emergency preparedness area next week. This is the 8th year of this webinar series, which shares issues and promising practices in emergency management, inclusive of people with disabilities and others with access and functional needs. The series topics cover emergency preparedness and disaster response, recovery and mitigation, as well as accessibility and reasonable accommodation issues under the Rehabilitation Act of 1973, the Americans with Disabilities Act of 1990, the ADA, and other relevant laws. Upcoming sessions are available at adapresentations.org under the Schedule tab in the Emergency Management section. These monthly webinars occur on the second Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific time. By being here, you are on the list to receive notices for future webinars in this series. The notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along the webinar platform with the slides. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the adapresentations.org webpage in the Schedule section of the Emergency Management area. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform, and the speakers and I will address them at the end of the session. So feel free to submit them as they come to your mind during the presentation. To submit your questions, as shown on the screen, you can type them into the chat area text box, or if you are using keystrokes, press Alt and H and enter the text in the chat area. If you are listening by phone and not logged into the webinar, you can ask your questions by emailing them to adatech@adapacific.org. That's ADATECH@adapacific.org. If you experience any technical difficulties during the webinar, you can send a private chat message to the host by typing in the chat window and type your comment in the text box and hit enter. And again, if you are using keyboard, You can use Alt-H to access the chat box. You can also tell us any technical assistance difficulties by emailing to adatech@adapacific.org or call us at 510-285-5600. Today's ADA National Network Learning Session is titled American Red Cross Disaster Response During the COVID-19 Pandemic. Inclusive emergency planning isn't as scary and out of reach as it sometimes feels. Emergency managers from city, county, and state level and FEMA's Region 9 disability this session will cover American Red Cross and the Red Cross efforts to make their efforts accessible during COVID pandemic. Today's speaker is Mary Casey-Lockyer. Mary is the lead for the Disaster Health Services at National Headquarters for the American Red Cross. She has deployed to 20 disaster relief operations, and she is currently assigned as the Senior Medical Advisor to the National Disaster Operations for the Red Cross. Mary serves as the Red Cross liaison to the Secretary of the Operations Center at the Department of Health and Human Services. So Mary, I will now turn it over to you.
Thank you so much, Louis. I hope you can hear me all right. Just let me know if you can or cannot. Thank you everyone for attending this presentation. It's a real honor to be asked by Louis and the group to present to all of you. I may have met some of you or even talked with some of you. So thank you again for attending. I really appreciate being able to talk about the American Red Cross and our disaster response during this COVID-19 environment. I did not put this on a slide because these numbers keep changing daily, but I want to give you a sense of the environment that we're in. So today's report, we have a little over 7.4 million COVID cases in the United States. We have over 210,000 deaths from COVID-19. Very, very sad. The case rate change for 24 hours, the past 24 hours is 0.5%. The 7-day rate of change for cases is equal to plus 4.8%. The case numbers have actually dropped 34.5% since July 24th. Sounds very good news. The deaths, the 24-hour change is 0.3% with a 7-day change of minus 4.6%. I think this really points to the fact that clinicians and healthcare providers are really trying to understand this disease better and tackling it in different ways. You might have heard a lot about dexamethasone that President Trump is taking, and that is a steroid, and they've learned this has really helped COVID-19 patients. Now I'll give you some other information, which is not so upbeat. So out of the 56 jurisdictions, that's states and territories, 30 jurisdictions are in a trend upward for COVID cases. 15 jurisdictions are staying somewhat the same, and 11 jurisdictions are trending downward. That's not so good news. The percent of ER visits, however, for COVID-like symptoms is only at 2%, and that is good. The positivity rate of the tests that are taken, it is 5%, and that seems like good news, but you really have to understand the denominator, and we aren't testing as much as we probably should be. I will tell you a little word about response right now. In the national shelter system, there are 12 congregate shelters. Not all of those have population. There's only 207 population in a congregate setting. In non-congregate, however, which is the hotel settings, there are 14,776 clients in those non-congregate shelter settings. And that includes the clients from the wildfires in California, from Hurricane Laura and Hurricane Sally, and all of the arrests. And now we have Hurricane Delta barreling down again into the same area of Louisiana, probably, that Hurricane Laura hit. So we are preparing for that. And I'll go through the presentation, and if you have questions about preparations for that, you can ask at the end. So as you see, we're going to talk about what Red Cross had to do because of COVID. So we had to create new doctrine, which is guidance. We had to create new processes, and we created a new virtual world. You'll see on the other side of this slide, you'll see a picture of a face shield, goggles, persons meeting virtually, a gown, N95 mask, and gloves, all of which we had to acquire if we had a congregate sheltering situation. So next slide, please. I always like to talk about the mission of Red Cross. I think it's very important for us to really understand what the mission is and to remind ourselves why we do what we do. The American Red Cross prevents and alleviates human suffering in the face of emergencies by mobilizing the power of volunteers and the generosity of donors. I have been pleasantly surprised at how many of our volunteers are willing to go out in this COVID environment and help all of our clients. Next slide, please. So what are the Red Cross's priorities during this COVID environment? Our mission has not changed, and that's why I read the mission statement there. Our mission definitely has not changed. How we deliver the Red Cross mission has changed. The safety of our workforce and clients is a paramount concern. The use of non-congregate settings for sheltering clients is preferred during this pandemic. Of course, it is safer to be in an enclosed area than in a large gymnasium. But everyone is welcome. That commitment has not changed. We will make every effort to get the resources that an individual might need due to a disability to them wherever they are located in the response. So next slide, please. So what are we looking at in this non-congregate shelter environment? Well, shelters, quotes, may include hotels, motels, RV campgrounds. A lot of that is going on in California right now. Single family cabins in campgrounds, or even tents. We have not used tents. We've had a couple of single family cabins, but we have very many, as you can tell, almost 15,000 clients in non-congregate settings in Louisiana and Texas. Now, the model for this non-congregate sheltering may include a reception center in the immediate aftermath where people can evacuate to. This, unfortunately, is a congregate setting, so we would have COVID-19 screening, but it may be limited in the reception environment. The goal is to get clients to a safer single room or cabin as quickly as possible. And again, our mission hasn't changed. Only the way we accomplish our mission has changed. Next slide, please. So we're going to talk a little bit about the non-congregate sheltering environment. Screening may be conducted at the non-congregate site for responders and clients. And this screening would include a temperature check, asking about any symptoms, asking if they've tested positive for COVID and how soon or how by 14 days, has it been 14 days since you've been tested? Important pieces of information. Disaster Health Services will conduct virtual wellness checks on every family household in that non-congregate sheltering. Well, I'll get to what we have learned already, but that was our plan. Let's put it that way. So we have an initial wellness check, which also includes what we call the CMIS interview. I hope many of you are aware of the CMIS model. which June Isaacson Kales put together many years ago now. And the Red Cross has adopted this model to help us discern the needs of the clients and to help the clients really identify their own needs. So C is for communication, M is for maintaining health, I is for independence, S is for safety, security, and most importantly, self-determination. T is for transportation needs. We've also added some questions around pre-event housing, which might alert us quicker to individuals who are experiencing homelessness or precarious housing. And so we can get our community partners started early on how to assist them to a more, to their recovery. We also communicate relevant client needs to the shelter site manager. So each one of these hotels has a site manager. They may not be there 24/7, but they would maybe go geographically from one place to another, maybe a couple hotels a day, so that information and the Red Cross clients can talk to a Red Cross representative with social distancing, by the way. In next slide, please. So non-congregate sheltering, if the wellness checks identify anyone with possible COVID-19 symptoms, clients will be asked to self-isolate in hotel rooms until public health or their healthcare provider gives them direction. We want to keep the continuity of care for our clients, and so we always encourage our clients to contact their own healthcare provider. Red Cross will notify public health and ask for guidance. The shelter site manager will also be notified, as will the facility manager be notified. This is not against confidentiality. The United States is in a public health emergency declared by the Secretary of Health and Human Services, and therefore this is a need to know public health information. Disaster health services responders, either virtually or on site, will continue to monitor a client's condition. And the CMIST interview is completed on all family units. Next slide, please. Thank you. So what kind of services are at the non-congregate shelters? Acquisition of hotels with ADA compliant rooms is a priority. We are well aware that we will have clients that will need to have an ADA compliant room, and that is a priority for us. Red Cross Disability Integration Specialists, in collaboration with disaster health services responders, assist disaster relief operations in meeting the needs of individuals with access and functional needs, including those with disabilities. That has been our normal plan, and it continues within the COVID environment. Assistance with activities of daily living can be provided by disaster health services responders who are licensed healthcare providers, or contracted personal care assistants, home health providers, or clients' own personal assistance caregiver. Personal protective equipment is available to these caregivers, and that means gloves, masks, and gowns. Needed supplies such as adult briefs, infant diapers, comfort kits, replacement of medication, durable medical equipment, sorry for the acronym on the slide, or consumable medical supplies are available and will be distributed to anyone in need. Next slide, please. Okay, non-congregate services also include any kind of unique diets, low sodium, low fat, etc. Safe sleep options for infants and toddlers will be available if not provided by the non-congregate setting. So pack and place, for instance, or infant sleep boxes. Translation services and assistive technology will be made available or acquired when the need is identified. Information dissemination, such as the status of the client's home area, re-entry instructions, available community recovery programs, FEMA registration, or Red Cross recovery programs will be delivered to clients through multiple modalities. including but not limited to text or email. Text has proved to be a really great way of communicating with clients. It appears that text is more palatable to clients than having many phone calls, and I'll talk about that in just a few minutes. Next slide, please. So there are challenges to the non-congregate setting. The geographic location of hotels may be widespread. And this is in order to acquire the needed hotel rooms, but also to acquire the needed ADA compliant rooms. So we have had issues moving people away from where the event occurred and having widespread hotels, which means a lot of work for our responders. Of course, there is some isolation of clients too. Clients will need to be more proactive in their own recovery journey to notify Red Cross of their needs. We have a wonderful story about a deaf gentleman who just couldn't get any information about the status of his home or what exactly was going on. So he decided he was just going to plunk himself down right in the middle of the hotel lobby and wait until he could find some information. And one of our Red Cross responders was able to communicate with him vaguely in sign language. And he got the information he needed, and he was very happy to return to his room with the information that he needed. So that will happen. The other thing about the non-congregate area is the high-touch environment. Clients are contacted multiple times for different reasons by responders, mostly in the virtual setting, so that means a phone call. So casework, disaster health services, disaster mental health, may contact the household primary contact multiple times a day. This can create a really big brother environment and cause resentment by the household. Now I'll talk about the lessons learned in a couple minutes. COVID-19 environment, our staff is skinny. Skinny staffing is a reality. And non-compliance of wearing masks creates fear, both for clients and responders. And so there is some non-compliance, as we know. We require masks be worn in common areas of non-congregate settings for responders and clients, and in a congregate setting for both also. Next slide, please. So what are the lessons we have learned already? And we've learned a lot. Everything takes longer in the COVID-19 environment. If we could do a task in 4 hours, it's going to take 8 hours. If we could find stable recovery solutions for clients in a week, it's going to take 2 weeks. So everything takes longer. Disaster response operational leadership will mostly be virtual, which has a learning curve. You have to learn the platform. We use Microsoft Teams. That's not an endorsement, that's just what we use. But it takes a while to get how do you conduct virtual leadership on these platforms. And so this takes some learning. And especially not so much with the job directors and other leaders that use it all the time, but when you have volunteers who maybe don't use that platform very often, except maybe for an occasional regional or divisional meeting, there's quite a steep learning curve. Personal protective equipment, parentheses PPE, you hear about that all on the media these days, might not be in the right place during the immediate response phase. We did have a question about where we had pre-deployed personal protective equipment, but in some of the early disaster response, it wasn't exactly in the right place for the event and had to be transferred, which was time. So we learned that. All right, next slide, please. The distribution of meals is different and requires different vendor collaboration. So what we are doing is using a single meal container for each individual. We set it down either on the table or near the hotel room, and then step back and the client retrieves that. So we have to have singly packaged meals which is a requirement that not all of our vendors can do. So it isn't the sort of buffet line like we would have in a congregate shelter. We don't have any Cambros. No one's spooning out something into a container for you. So an individual meal, and it does require a different feeding strategy. Pet care must be factored into the equation for hotel acquisition. We don't want anyone not evacuating just because we can't get them a hotel room that takes a pet. So this has been a challenge and something we've worked on. Signage is harder to place in non-congregate settings. So we have some very big hotels in New Orleans right now, but they belong to Hilton and Residence Inn and all the other kinds of facilities. And so it's harder to put our signage into a hotel lobby where there might be other guests that haven't been affected by the hurricane. So that's been a challenge around communication. And then next slide, please. So we have had to utilize some contract staff, and the contract staff may be needed to meet needs, and this process takes time and requires on-the-ground supervision. So we have had to get some contract staff, both for health services and for some other functions, and it does take time to get them on the ground and know our processes. Red Cross recovery programs will need to use more virtual options. In-person client casework will require a higher level of protection for client and responders. So if we are doing shelter transition casework, which you might have to do if your home was completely destroyed, we have now acquired plexiglass walls so that we can actually talk with the client at a table. And I think that's sort of what you see in your grocery stores every day. Local and state public health entities are stretched and may not have the capacity to assist with testing, screening, or contact tracing. It's just the reality. Social distancing to 6 feet is hard, and it's difficult to calculate the 6-foot distance. So you can see it in pictures. You can see it on TV when there's a reporting of some event that although people are trying to be 6 feet apart, nobody really knows exactly what 6 feet means. The other thing is, I think in general, when people put on a mask, they feel protected. But what is happening with that mask is they're protecting others. It's not protecting them. But they feel as though they're a little bit more invincible, and so may not need to be 6 feet apart. And that has been a challenge both for responders and clients too. Next slide, please. So now I'm going to move into the congregate sheltering world. This is inevitable. And I have up here, inevitable if large hurricane or wildfire occurs. Well, we are here. And we just this morning heard that the state of Louisiana is planning for 3 shelters of about, I think it was 1,000 each, or 500 each. And they are planning for congregate sheltering in response to Hurricane Delta. Whether that will actually occur or not, we're not quite sure, but that is the planning that is going on. Lots of hotel rooms are being taken up by the almost 15,000 people in Louisiana. So they will be here. We will have congregate sheltering. We hope to keep them small, probably to 50 people each. But evacuation centers are required to have 60 square feet per individual. That's quite a bit larger than normal. Congregate shelters post-impact, we will try to have 110 square feet per individual. We have a little banner on the side of the slide that says that this will cut the shelter capacity by half. And that is the truth. And that will be all over the United States. Screening and isolation care areas will be established. Only disaster health services responders will work in these isolation care areas. And this is for symptomatic clients and probably their families for any kind of disease. So, we had a horrible norovirus outbreak in the California wildfires a couple of years ago, and the state of California was wonderful in helping. But, there's all sorts of infectious disease that could happen in a congregate setting. So this is not just for COVID. Local public health agencies will be notified of each client in isolation care area. Again, this is due to the public health emergency that has been declared and extended by the Secretary of Health and Human Services. So next slide, please. So this is a picture of how we would set up a congregate sheltering operation. As you can see, the event occurs, cause for need of the emergency sheltering. We hope that this would be less than 14 days. What I do know and heard this morning is that Louisiana may have congregate shelters until the storm passes, and then the clients will be assessed for need for non-congregate, and they will be moved into non-congregate settings as quickly as possible. We pretty much assume that public health may not be present, and the reason is because they are trying to respond to a massive pandemic. As you can see, the client stick figures here are going to enter into the screening process. There'll be 2 Red Cross screeners. They may be asked, or they may want to go to friends and family, or if they're critically ill, they may be transported to a healthcare facility. But this is really around, can you manage in a shelter? If you have mild symptoms, so you're not critically ill, but you have mild symptoms of COVID, you would be asked to go to the isolation care area, which you can see at the bottom of this picture, and there'll be more questions asked there by a licensed healthcare professional. It could be that the 2-year-old has a fever because they have a very bad earache. Well, they may be asked to go to the door of the isolation care area, but when the healthcare professional finds out that there's an alternate diagnosis, they're going to be directed into the general dormitory area. So there will be a door. There will be the shelter size, we hope, will be 50 people maximum. Families certainly can be together. Everyone leaving the facility must be rescreened upon return within conditions. I mean, if you're gone all day, definitely you will be rescreened. If you step outside because you want to smoke a cigarette, we probably won't rescreen you. Red Cross will have a team of 5 plus 2 more maybe. There'll be a shelter manager, a safety person, a health services person, a logistics person, and some mass care. The isolation area will have additional health services staff and separated with a barrier. Next slide, please. I'll talk to you about staffing in the congregate shelters. In Red Cross managed shelters, every effort will be made to have 50 or fewer clients in these shelters. And I really understand that Red Cross manages many shelters, but not all shelters. And so there are counties and parishes who run their own shelters. There are other independent, like faith-based organizations who run shelters, and they may not have these same criteria for staffing or guidance or doctrine around how they run their shelters. A Red Cross shelter strike team consisting of a shelter manager, shelter supervisor, 2 shelter workers, and 1 disaster health services responder will staff Red Cross managed shelters. 2 additional disaster health services responders will be added to the team if an isolation care area is needed. As I reported earlier, disaster health services volunteers are licensed healthcare professionals, and so they would care for clients in the isolation care area and not the general volunteer. We also would be able to assess the client, and if they needed transfer to a higher level of care, we would make that referral. Clients will be recruited to assist with the management of the shelter, so it's all hands on deck. If you're a client, we're going to possibly ask you to help sweep the floor or clean off surfaces or something like that. So next slide, please. This is a picture of the isolation care area. As you can see, we have cots separated by 6 feet at a minimum. And each cot would have a chair. There'll be multiple tables in the room. There'll be multiple hand washing stations. There'll be one entrance in. You can see that there is a room for personal protective equipment storage for those working in there, and a place for them to take all that off and dispose of it coming out. We would hope that there's a separate exit out, here for if there were portable showers or portable toilets, especially accessible ones. We want a separate exit for anyone in the isolation care area. Refuge is just places where clients can put their tissues or whatever they're throwing away. So next slide, please. Here is some hopefully universal signage that we put together. This is the English version. We do have it in a Spanish version, but it's signage around all individuals entering the shelter must be health screened before entry. Family units or individuals must maintain 6-foot distance from others. You can see a picture of a healthcare provider and another client for a screening area. We thought it would be appropriate to have I'm here to help signage because people may not be seeing people, although face coverings now are pretty much all over. So it's not as scary a sight as when we first put this together early on. We have signage for the isolation care area with an individual who's masked and authorized entry only. We also have signage of goggles, masks, gown, and gloves for personal protective donning area and where they would take it off. So those are some of the signs that we have put together for our congregate sheltering. And next slide, please. So what have we found as far as challenges? Clients and responders may feel uneasy in this setting with many people. It's just a fact. I know even myself, when I go to the grocery store, I don't go very often, but when I do, it's a little unnerving to be around so many people. Wearing of face coverings is required by both clients if you're over the age of 2 and responders. There are some exceptions, of course, and we would have to make accommodation for that, and we would. Use of restrooms while practicing 6-foot physical distance is difficult and can decrease restroom and shower capacity. Continual screening of those coming in and out of the shelter is labor intensive and intrusive, and weather certainly could be a complicating factor. We've actually had plans to make a long hall, say in a school building, as the screening area because of inclement weather. State and local public health entities may not be available for screening or work in the isolation care areas. We have had some success, I think it was in North Florida, where public health actually came into a congregate setting and did do COVID-19 testing, but that is not what happens all over the country. So local public health is really swamped with just this response. Next slide, please. And here's some lessons learned already. Congregate shelters will happen. The use of face coverings is required. Emergency management and public health entities are stretched due to COVID-19 response alone. And adding a disaster to COVID-19 response is difficult. Feeding requires a different set of skills to produce single wrapped meals delivered with a 6-foot physical distance. And the COVID-19 environment makes response and recovery harder, and it takes longer. Next slide, please. So here we have a picture of people not 6-foot distancing, which I didn't really catch until I just looked at reviewing this today. So even I have a problem with 6-foot distancing. But this is about responder help. So next slide, please. So responder health really is critical to disaster relief operations. If we don't have a healthy workforce, we can't respond. All disaster health services responders, virtual or on-site, will act as staff health. So all the licensed healthcare providers that are our volunteers will help everyone, clients, and our other responders. Workers on site will be screened before entering the work site, so they'll take their temperature in their lodging, and then again, their temperature will be taken at their work site before they enter the work site. Workers will be directed not to report to their work site if they are ill for any reason, and staff health will then follow up with the worker. We really don't want you to be on the work site if you feel ill for any reason, whether you think it's COVID related or not. American Red Cross, also as a corporate entity, has an internal process to report COVID-19 employees or responders to our human resources entity. And so we have been doing that. We've had a couple, I don't want to give an exact number because I'm not sure it's right. I think it's only been about 3 or 4 who have tested positive for COVID-19 while on operations or shortly after returning home. We have really encouraged our responders, if the community has testing, which many communities do now, to get tested a couple of days, more than a couple of days, maybe 3 or 4 days before out processing or leaving to go home. Or if that's not available, after getting home, wait about 2 to 5 days, because 2 to 5 days is the mean incubation period for COVID, and get tested prophylactically just to make sure that you are safe. And so again, next slide, please. So I will just want to point out what hasn't changed. So Red Cross Disaster Relief Operations commitment to diversity and inclusion, everyone is welcome, has not changed. No individual with access or functional needs will be turned away from Red Cross non-congregate or congregate shelters. Red Cross commitment is to work closely with local and state public health to maintain the optimal health of staff and clients. Next slide, please. So we've heard this over and over again. We are all in this together, but it couldn't be more true. We are all in this together. Please wear a face covering, social distance 6 feet or more if you can. Wash your hands often. It's important to wash your hands because this virus has a little fat molecule covering, and the soap and water will break that covering and won't allow the molecule to replicate. So please, again, face coverings to protect others, social distancing to hopefully protect you, and washing your hands to get that little fat molecule broken up. So that's all the slides I have. I'm very happy to take answers or questions, I mean. And if you can just put my contact information up on the next slide, that'd be great. So Louis, I'll hand it over to you for the questions.
All right, Mary, thank you so much. That was tremendous. All right, everyone, remember to submit your questions in the chat window and we'll address these. And let's start with the first one, sort of going in order of when we receive them. So is there a virtual option for registering at the welcoming centers in the non-congregate shelter?
So there was an option to do that in Texas. The reception centers are not necessarily Red Cross managed. As a matter of fact, neither in Louisiana, that is not Red Cross managed. It is the state that is managing, and so as it was in Texas. In Louisiana, I know that people exactly have to go to a reception center in Alexandria, Louisiana in person, but that's the state's direction. So we don't necessarily manage. We may staff a reception center, but we don't necessarily manage it, which means it's up to the state or parish or county to give direction to the clients.
All right, next question is, are the CMIST interview results used to inform whether a family is placed in a hotel room versus a congregate shelter?
No, actually, it's not. It's more to inform what the client needs are that the client identifies. So if the client needs, say, a low sodium diet, or they need a diabetic diet, or they lost their mobility equipment for some reason or other, that's what we're trying to do with the CMIS. It is not a criteria for a hotel or a congregate setting.
All right. And at one point you referred to skinny staffing. I think we know what you mean, but somebody was asking, could you explain what
It means our staffing is not as robust as in the pre-COVID environment, because many of our volunteers are over 65, have comorbidities, as you hear about on all the media, that make them more at risk for serious COVID infection disease process. So some are choosing not to be on the ground, but they are supporting virtually. I'm just really amazed at how many people are really supporting. I mean, we had as many as 3,000 volunteers assigned at one point, I'd say about 10 days ago. And that was a mix, probably 50-50, of virtual and on the ground. So that's an amazing response.
And that kind of ties into the next question, which was how has the COVID-19 context affected the type and number of Red Cross volunteers that are available? And then do you see the same phenomenon happening with other VOADs?
It has changed the type to some degree. We have had a seasonal readiness campaign that has recruited and required less training of volunteers. And many of those seasonal recruits, I think, are a bit on the younger side and feel that they can go on the ground. We've given them less training and tried to mentor with a more experienced person. So it has changed. I will tell you, there's some VOADs that are not deploying at all on the ground during the COVID environment. And so I'm pleased that Red Cross is able to, accomplish our mission with a mix of virtual and on the ground.
One person confirmed just got back from Louisiana, and pet care was a big problem. So just wanted to add that in there.
Yeah, this is Mary. I know that it would be a big problem because sometimes hotels do not want pets in, and so we've had to use some partners sometimes in other areas, not necessarily Louisiana, but I know that pet care can be a real challenge.
Okay. You may have answered this before, but let me ask it anyway. Another person is asking, how are clients determined and prioritized for the non-congregate sheltering?
Again, those are if a reception center is utilized. The California wildfires did do that. There wasn't really a prioritization. We just wanted to move everyone, not we, the state who runs the temporary evacuation points, wanted to move everyone into a non-congregate setting as quickly as possible. So again, it's a criteria of the state, and really it's everybody in a non-congregate as quickly as can be.
Yeah. And the next question, and I will answer this one for you, but someone asked, what is refuse? And I think this refers to in your graphic of the shelter. Those are the trash cans.
Right. Thank you, Louis. Yeah.
Yes.
yeah, it was in the schematic. The reason we put that in there is because we want to make sure that clients, if they're coughing, we want them to cough into a tissue, right? We're going to give them tissues. We're going to give them a plastic bag to put those tissues in, and then we want them to throw it out because we don't want it under the cot or on the chair where somebody might inadvertently touch it.
Yeah, I think that is actually a great point. It's more than just the silliness of that's the trash can, but that's actually a way to keep down the infectious particles. So that's great point. Next question. How do you handle individuals who, because of their disability, cannot wear face coverings? Do you have shields?
We do have some shields. They take a little bit of time to get to the event, but we do have some, and that would be an alternative. We'd ask if the person could tolerate a shield. We try to make sure that the person had enough space for themselves, but away from anyone else. So it would probably be more than 6 feet social distancing. We'd want them to have as much space between them and the other clients as possible. And if we had a separate room, that would be great. It's not always available. But again, we would do everything we could to protect them, and face shields would be one option.
Next question. Can medical Red Cross volunteers practice to their full license?
Thanks for that question. Yes and no. So registered nurses, licensed practical nurses, and licensed vocational nurses do have full scope of practice. Physicians, physician assistants, advanced practice nurses, nurse practitioners do not have full scope in that they cannot write prescriptions while volunteering for Red Cross. So they can't diagnose and treat while they're volunteering for Red Cross. They can make assessments and referrals to individuals who do have full scope of practice in that state. I think, as you can imagine, it's very difficult for a physician to have full scope of practice because we would have to credential and privilege them like many healthcare facilities do. And those healthcare facilities, I'll tell you, have staffs of 5 to 7 full-time equivalents to do that. It costs thousands and thousands of dollars to credential and privilege physicians. So that is one reason we do not have them. The other is a risk tolerance. We know that nurses are generally much less risk than a physician because a physician can write that prescription. So, but we certainly partner with other partners such as Medical Reserve Corps. They have full scope of practice because they usually only function very locally in the state where their license is recognized. And then we've recently had a partner with the company called Teladoc, which is great because that's telehealth, and really telehealth has taken a big boost from this COVID environment. So we have a very nice partnership with them, and they will take calls from the client in a private area, and they can prescribe and diagnose, and they've done quite a lot of work with us over these last few months.
And Mary, we kind of lost your audio a little bit when you were talking about the difference between the nurses and the physicians couldn't do what?
Oh, I'm sorry. Physicians, nurse practitioners, advanced practice RNs, and physician assistants cannot write prescriptions while they are volunteering for the American Red Cross. They cannot diagnose or treat. They can do assessments, but they can't diagnose and treat.
All right. The next question has to do, I'm going to kind of summarize because it's got several parts to it. So when someone is arriving, is there ASL interpreters available? Do you use video remote interpreting? And are they on site all the time, or do you only use VRI?
Louis, yes, we only use VRI. Now, we can acquire ASL interpreters, but it does take some time. So our computers that are on site have the ability for VRI.
And they follow up with another part of that question, which is, are the forms easy to understand? Because this person notes that some forms may be hard to understand for some deaf people as English is really their second language.
The registration form, I think, is very quick and easy. It's just head of household name, names of the people in your family, and very simple pre-event address. And actually, the client doesn't necessarily doesn't necessarily fill it out, it would be a responder, and so they would be able to help them.
All right, next question. How are you promoting the next generation to help with response if the usual volunteer base is compromised?
Great question. This is tough. I mean, we all know that young adults, they're not really in a place in their life. They're starting families, they're starting jobs, they're looking for jobs right now. It's really tough. We have had some younger generation folks come our way that are out of work right now, and they can volunteer, and they have. And so they are introduced to the Red Cross and what disaster response looks like. I think it's a challenge for all of the voluntary organizations active in disaster to really get the next generation on board. And I think hopefully when this all settles down a bit, that will be a real focus for all of those voluntary organizations.
All right. Who is funding the non-congregate shelters?
It's a mix, actually. The funding for the non-congregate shelters either can be the state or it can be Red Cross. There has been a change in the public assistance policy of FEMA, which can reimburse a state for non-congregate sheltering costs by their change in this public assistance policy. That was done very, very early on. It used to be that you have to have prior consent by FEMA for the state to do non-congregate, but that has been kind of taken away. And so the state now can ask for reimbursement by FEMA, and that's how many of them are being funded. However, if you have a multifamily fire, it is the Red Cross who is picking up all of the funds for that in the non-congregate setting, and in some of the disaster relief operations also. So there's negotiations with the state, but it really is the state will be reimbursed by FEMA under public assistance for this.
Okay. So the next question is, when did Red Cross first start using the CMIST definition as part of its screening for the shelter settings?
Oh my, you're really going to test my memory on that, aren't you? I think that it was actually the form was put together in 2011, but I believe, and if June, if you're on the line, you can answer in the chat. I think she developed that model in 2008, and maybe it was even before that, but it might have been 2006. So it's been around for a long time, but it's a wonderful model to really. It's especially good for healthcare providers because it kind of pokes them out of the medical model. And so we wanted them to think more about function and less about disease. And so I think that model really helps to do that. So we were very pleased to, really adopt that as our philosophy.
Right. And I don't think June is here today. So we'll go on to the next question. And this goes back to the VRI issue. As people have noted, the VRI really needs to have broadband or Wi-Fi to make sure that the video is consistent. Do the congregate shelters have high-speed internet?
Not all congregate shelters have high-speed internet, and I am not the expert on the VRI. I know that there is an application that we have on our shelter, on our computers that are brought to the shelters. I'm just not exactly sure of all the technical knowledge of that. So I would really point you to Sherry Myers, who has more of the technical knowledge on that particular application.
Right, okay. Yeah, I think that's what's being raised is a common issue with VRI. As I mentioned before, that you need a good connection to be able to make sure that you're not dropping any frames or anything. So as you can see from even on the video that we're seeing today of our ASL interpreters, if you missed or lost a connection with that person as they're signing, the meaning might get somewhat uh, scrambled. So anyway, there is somebody who asks if they can ask you a question in private after the class. I think you have, to the person who asked that question, you've got Mary's email right there on the screen, mary.casey-lockyer@redcross.org. Feel free to email her and she'll answer those questions and whatever question you might have. I think I'm answering for you, Mary.
Absolutely. That's great, Louis. Thank you.
And okay, for those of you who are asking if you have a copy of the presentation, that is available at the adapresentations.org website in the schedule section of emergency management. Today, tomorrow, it will be in the archive. Okay. Oh, here's an interesting question for you. What do you love about your job?
Oh my, that's a great question. Well, I in my other work life, I was a critical care nurse, and I took care of one patient or maybe two patients at a time, or three if it was really bad. I remember that I changed to being a housewife supervisor, and I certainly missed that bedside contact. But what I've come to accept and embrace is that I am a nurse to 330 million people in the United States. And so I do really enjoy that. I feel it's a very special privilege to be a Red Cross nurse. I don't know how much you know about the history of Red Cross, but nursing was very much focused in the early part of the Red Cross, American Red Cross. It actually started the home health care in the United States. And so it's really a privilege to be a Red Cross nurse, and I am really honored by being able to do this. And I do love the sort of the way you get to understand that this is a nation of very different states, and it can be a challenge at times. But it's great to have sort of that federal outlook around what's happening in all of the United States. So yes, I do really love the job.
All right, very good. So again, for those of you who are writing, the archive will be available for this webinar next week, and it will have the transcript. It'll have the replay of this recording and all the slides. So you'll be able to get that next week at adapresentations.org in the emergency management section. We realize that many of you may still have questions. It looks like we're actually at the end of the questions. So except for the person who has a hand raised, if you have a question, go ahead and put it in the chat room while I kind of roll through the rest of this. So if you have a question and you didn't get a chance to ask it, or you want to ask Mary separately, you've got her email there on the screen. If you have a question related to this that has ADA implications, you can also contact your regional ADA center at 1-800-949-4232. And you can ask that question and our technical assistants can answer those for you. You are all going to receive an email with a link to an online session evaluation. Please complete that evaluation for today's program, as we really value your input and want to demonstrate the value to our funder. We want to thank you, Mary, for sharing your time and knowledge with us. I think people were very happy and a lot of thanks coming in the chat room.
Louis, I just have one thing I wanted to break in on,
Yeah.
and just, which I forgot to do, is I'm really encouraging everyone to please get a flu shot. It's critically important this season to get your flu shot. You don't get the flu from the flu shot, so your arm might be sore, but please get your flu shot. Again, critically important. If you are an age where you need a pneumonia vaccine, get that too. I got mine, probably about a month ago. So, please ask your healthcare provider what you need. Stay up to date with adult immunizations. It's very important this season.
All right. Okay, and one last reminder, of course, that today's session is being recorded, and it will be available for viewing next week at adapresentations.org in the archive section. The next webinar will be posted on adapresentations.org in the schedule section of emergency management. Since you're here and you will be on the list and will receive a notice of the opening of the registration for that when we put that up there, and that will be 2 weeks ahead of the announcement of that registration. All right, well, thank you all for attending today's session. Thank you again, Mary, for your time and whatnot, and thank you to the captioner, and thank you to the ASL interpreters, and for all of you, have a great rest of your day.
Thank you, Louis. Thanks to everyone.
Bye.